emphasis on cancer disparities. And so I'm delighted to co-chair this panel with my colleague, also at Fred Hutch, Dr. Bhatia. So I think at this time we'll invite our panelists forward so that they can get ready for this session. So the way that this is going to be a session that we hope will be quite interactive. We've asked each of our speakers to give our panelists really, to give very short presentations, about 3 slides each, just to kind of give you their perspective on this topic, and then we'll move into an interactive Q&A session. So with that, I'll invite our first panelist to come forward, Dr. Hiba Khan, who is an assistant professor in genitourinary oncology at University of Washington and Fred Hutch. And she has a research program focused on prostate cancer outcomes with primary areas of focus including cost of cancer treatment, access to care, and disparities in cancer care. So welcome.
Okay, hi everyone. Thank you so much for inviting me. This is one of my favorite conferences of the year. It's lovely to be asked back. So I'm going to just share something very brief about disparities in precision oncology studies. And I chose to focus on this just because studies are sort of where we get our guidelines from, is where we establish standards of care, and kind of starting very, very early and discussing the disparities in actually enrolling folks in these studies, I think is really incredibly important. Here are my disclosures, none of which are relevant to this talk today. So I'd like to start by sharing 2 studies. This study is quite old now, it started in 2015, but it's really important. This is a study that looked at a meta-analysis of drugs approved by the FDA for cancer from 1998 to 2013. And you can see this was kind of in the very early age of precision oncology, when people were kind of getting very excited about precision oncology and medicine. And this meta-analysis looked at 112 trials that led to 58 FDA-approved drugs, 38,000 patients, so quite a high number of patients. And they looked at personalized versus non-personalized strategies for treatment in patients, and found that a personalized strategy in these clinical trials, when they analyzed independently through meta-analysis, they found that the response rate, the progression-free survival, and overall survival was better in those trials that actually tested precision oncology drugs. And then the next study I want to highlight is this one. This was also a pretty large study where they looked at almost 6,000 patients. This was published in 2021 in JAMA. They looked at 93 precision oncology studies, including patients that had breast, lung, colorectal, and prostate cancer. And they basically looked to see how the representation was in each of these studies compared to the US population. And so this is kind of their primary figure here. So you can see, things above the line include overrepresentation, things below the line include underrepresentation, and you can clearly see that the non-Hispanic white population is overrepresented when we compare them to the general US population. Asian population is also a little bit higher, which I think is interesting, but only 4% of the patients were Asian, so there's a little bit of a limitation there. But you can see minority populations like American Indian, Pacific Islander were low. Black patients and Hispanic patients are all underrepresented in precision oncology clinical trials. And then this is just a breakdown, I'm not sure if you can see this, through the different cancer types. I look at prostate, which is my sort of area of interest, and you can kind of see all of the minority populations are very underrepresented in prostate cancer, and breast, colorectal, and lung. And I'll end by putting in a huge plug for clinical trial navigators. Like this was a New York Times article, and like they said, fewer than 5% of cancer patients participate in research that could improve their care and lead to more drugs available in the market. And so it's important to do community partnerships, address social determinants of health, and I'm really a strong believer in patient navigation, including for clinical trials. So looking forward to discussion. Thank you.
My name is Jerald. I'm a medical oncologist. I'm based at Fred Hutch, and I focus on skin cancers and immunotherapy. And my connection to disparities is I'm a big fan of Binay and a big believer in the mission that he is embarking upon. And I'm also trying to focus on some trials, trying to bring immunotherapy to the underserved areas. So it's my great pleasure to be chairing this session with Dr. Lee, and our next panelist is Dr. Monica Yellowhair, and she joins us from University of Arizona, where she works on improving or reducing disparities for the American Indian tribes. And I'm going to try this. She belongs to the Towering House people, which is pronounced possibly as Kinyaani. I don't know how good or bad it is. You'll tell me. And born for the Red House people, Kinlichini. I'm probably butchering it. Sorry about that if I am. And her maternal grandfather is in the Manigoats clan, Tlizilani, and her paternal grandfather is the Reed people clan, Lok'a'adine. I don't know how good it is.
Well, I will give you kudos. Most people just read the English portion of it, but I will say my clan's in Navajo. So Yat Bennett. My name is Monica Yellowhair. As Dr. Lee as I was just introduced, I am of the Kia'ani people. My paternal grandfather, or my paternal clan is Tla'atlana and Kia'ani, Kitlachini, and Tla'atlana. So those are my clans. So quickly, my presentation is going to quickly echo what was just previously heard and from the previous session. And so again, my role is to work on reducing cancer disparities in tribal communities. And so just to kind of think back and bring back to how Native Americans conceptualize health and disease in our communities. Yes, we talk about social determinants of health, but what is also missing when we talk about social health determinants of health, we forget to think about resiliency and what our people have gone through in this country. We look at community as a whole, we look at family, we look at how it affects our spirituality, our emotional, our physical, and mental well-being. So thinking about that and also talking about how a lot of these disparities are complex and how it reflects social and economic disparities more than biological differences. And so up to this point, cancer was not a word in our languages. And so a lot of the tribes lack a word. So for example, for Navajo, when we first started talking about cancer and how we address cancer, we called it the sore that never heals. And so that gives the connotation of it's very bad. It's a death sentence, basically. But over time, as we talk about cancer more in our communities and learn and educate our people, that term has actually translated to something more along the line of the cell that keeps growing. And so you could get a different connotation about that. And so, again, this is something that people need to consider when we're talking about our approaches for prevention and treatment. And so, and not only that, we as a people, we also have our own traditional healing ceremonies and our own prevention strategies. And so some of these should be incorporated when you're addressing Native communities as well. And so when we talk about cancer patient by the numbers, we talk about how rural Arizona is. We have 22 federally recognized tribes. In Arizona, we have a population of over 362,000 people. A lot of the tribal lands have no cancer centers as of July 2019. And so patients must travel long distances, in some cases up to 410 miles round trip just to get cancer care. And so I have a little map, I don't know if you can see it, but this is what the Four Corners area looks like. In Arizona, we have 3 major cities, Flagstaff, Phoenix, and Tucson. And so when you break that down, you think about how many oncologists they are to serve people. And so for example, Flagstaff, you have 1 oncologist for every 1,500 people. Phoenix, 1 oncologist for every 12,000 people. City of Tucson, 1 oncologist for 7,000 people. However, the Navajo Nation, which is currently the largest tribe in the US, you have 0 oncologists for 173,000 people. So that is another thing that we also have to think about. So some of the work that we have done at the University of Arizona with our Cancer Moonshot initiative is to increase colorectal cancer screening rates among the tribal communities across the state. And so we implement this with using navigators, patient navigators. And so we hire navigators that live within the community, who know the community members. And so they had a huge role as far as education, patient reminders, assessing barriers, doing a lot of interpretation, delivering fit kits, picking them up, and also linking patients to the support that they need for colonoscopy referrals. And so they had a huge hand in the wonderful work that they've done. And so this just shows the impact of their navigation. So our navigators contacted over 1,200 patients across the state. They delivered over 1,000 fit kits, and with that, 52% of those fit kits were developed. Out of those fit kits that were developed, 15% were positive, and then out of those people who had a positive fit kit, 60% completed their colonoscopy, whereas some of the patients, they wanted to forego the FIT kit and go straight to a colonoscopy, so they were able to get 89 people scheduled for the colonoscopy, and out of the 89 people, 70% of them completed their colonoscopies. And that's huge when you look at the national screening rates. Historically, you have Indian Health Services with screening rates for colorectal cancer being below 30%. In the clinics that we worked with, we've seen colorectal cancer screening rates increase by 46%, 155%, and 17%, and this was during COVID-19. So this shows the impacts that navigators really have, and so if this is just for screening rates, can you imagine what that can do for oncology and also getting more people signed up for genetic testing? And so with that, I want to thank you. Oh, sorry. And so that's my contact information, and I'm happy to answer any questions later on, so thank you.
Thanks so much for having me here. I'm not an oncologist, I'm an internal medicine physician, but I trained at Rhode Island Hospital. A great place. I don't know if Dom Tomorrow and Shelley Sear are still there. So I took this topic from the perspective that it's difficult to implement precision medicine therapy across populations unless you are able to, on the front end, deliver the right precision medicine testing. And a lot of barriers to precision medicine come from the inability to get appropriate testing up front, and this is a cause of disparities, and I'll talk a little bit about why. So let's see how I do this here. I will hit this button, see what happens. Wow, it worked. So, you know, I have 3 points or areas of focus, really from sort of least to worst. And when I talk in this first slide about physician education, I don't really mean that physicians don't understand NCCN guidelines, they don't know how to use NCCN guidelines. They do. But NCCN guidelines are changing, they change rapidly. I'll give an example. Within the last month, the guidelines for pancreatic cancer have changed to state that all patients at all stages should have next-gen sequencing, and that should be comprehensive next-gen sequencing. And there was a particular focus and a sentence placed regarding the need to also do RNA testing because many gene fusions are found at the transcriptomic level, and if you don't test for RNA, you're going to miss them. So, you know, it's really hard to keep up with NCCN guidelines. So physicians know and look to deliver guideline-based gold standard therapy, but it's really hard to keep up. It's also really hard to look by disease state if you are not in an academic medical center and you have to treat all solid tumors and many heme malignancies. It's really hard to cover the entire scope of cancer and get an understanding for each specific disease, the utility of testing, as well as figuring out, oh, okay, I have this patient with this cancer at this stage, with this performance status, and this genetic makeup in the somatic tumor. Now I need to have a choice of drug A, B, or C. These are tough decisions that have to get made in a busy day for a community oncologist who's seeing maybe 20 people. So you've got some areas where it's tough to keep up with the guidelines, tough to figure out how you transact that, and tough to get it to patients. And that's really actually the least of the problems. More of the problems come from the fact that the commercial insurance industry has not kept up. If you look at the policies of the major insurers, you'll see in the reference section studies dating back to 2015, 2018, 2020. Even studies of 2021 and 2022 are currently out of date. And so creating utilization management policies that are transacted into you can't have this, you can't have that, you have to pay for this other thing yourself, it's outmoded. And that's because the technology is moving very fast. And when I did this assessment, I was being very kind. I wouldn't say that the green is totally green for a lot of these. So this is probably a best case scenario. You know, the national carriers are lagging from Medicare. Medicare had a national coverage decision, NCD 90.2, and they were actually a leader. That was from 2017. Amazing, our government is leading. So they were. But that actually stated that for solid tumors, you could and should have comprehensive genomic profiling for advanced, recurrent, or metastatic disease. And they're now debating how to upgrade that in 2025. And in part of my company, I go to some of these advocacy group coalition meetings, and we bombard CMS with letters, and we'll see what happens. But CMS is way ahead of the commercial payers. As a matter of fact, I was just talking to, a few weeks ago, somebody from a couple different people from large pharmaceutical companies, and I said, because I worked for J&J for 5 years, I said, you know, you think you have gold-plated insurance, but your own insurance doesn't cover the testing that would allow you to detect the diseases that your company is spending billions of dollars to create targeted therapies for. They didn't like that. Anyhow, insurance policies are a problem. The biggest problem is the fact that the insurance industry has layered upon the complexity of precision medicine administrative barriers that are really hard for offices to overcome. Oncologist offices are designed to treat patients. They're not designed to treat insurance administrative paperwork. And depending on the size of your office, if you are not a large office, if you do not have a very large administrative staff to oncologist FTE ratio, you'll just not be able to overcome a lot of these administrative barriers. And this is especially true for oncologists who are in non-urban and rural practices. They're not big groups. They don't have a lot of technology sophistication. If you're in a rural environment, you don't have Epic as your EMR because you're not connected to a hospital. It's really hard to get the right set of processes to be able to say, I want to order this test, and this is the justification, and please don't have somebody, and I don't want to name names, I don't want to have a representative of a large Medicare Advantage company that's publicly traded call me and threaten to kick me out of the network if I order this test again. That's really happening. So this facial representation is real. This stuff happens, and it disparately affects those of low socioeconomic status and those of low educational status who can't fight for themselves. And I'll just end by saying it's very ironic because if there was actually a way to operationalize the set of data needed to do appropriate prior authorization, I'm not against prior authorization. I spent 10 years at Aetna, and I did every job under the sun there, including starting their National Oncology program for medical homes. So I know how this works. It could be easily automated, but it's not, and that's for a reason. So insurance companies are losing money because they're spending millions of dollars having butts in chairs, taking faxes off machines and getting phone calls to either approve or deny these prior authorizations. And they also, per the previous speaker, don't understand that if you got comprehensive genomic profiling, you'd be able to recruit 5% of your patients for clinical trials. And guess what? The cost is not in the testing. The cost is in the therapy. Testing might be $2,000, $4,000. Therapy might be $100,000 to $300,000. And testing is one time, or depending, if you need to do minimal residual disease, that's another story. But it's pretty limited. Therapy is for as long as the patient's around. So you could lop 5% off the top if you just did the right testing, but they seem to be resistant to hearing that. Thank you.
So we did have a fourth panelist, but he is actually giving a seminar right now and was trying to get here as fast as he could. He obviously didn't make it quite in time to give his presentation, but hopefully if he comes, he can join us here on the panel. So I think, yeah, let's open it up to questions. We have about, I think, a little over 30 minutes for discussion.
Banu Symington. I'm a Wyoming oncologist, so there are 5 in a state with a population of 500,000. Not zero, but pretty poor statistics. I'd noticed, however, that North Dakota, which is also plagued by rurality, has great HPV vaccination compared to Wyoming, which has terrible HPV vaccination. But that's not my question. You mentioned NGS testing. And this is a first world problem rather than a third world problem, although Wyoming is much like a third world country oncologically. I get referrals from physicians at many hospitals, and the surgeons don't order the NGS. By the time I see the patient, they have recovered from their surgery. They're 4 weeks out. And for me to order the NGS delays their care another few weeks. I'd like to bring up the possibility that we shift. Every time I bring this up, they say it's because of insurance. It would be nice if we could educate our colleagues and if they could get insurance approval to order the NGS at the point of service.
Yeah, thank you for bringing that up. There has been a misinterpretation and misunderstanding of something that is both a public payer and private payer policy. The public payer side, and you can look this up, it's called the 14-day rule. You're probably very familiar with that. The 14-day rule says that for Medicare patients who receive certain testing within the hospital must pay for that testing. And there's an exception to the 14-day rule that says that as long as that test is sort of read or performed post-discharge, and I don't know if it has to be 14 days or not. I don't think it has to be 14 days, that it is exempt from the 14-day rule. So people are not ordering appropriate next-gen sequencing testing because they think they're going to get in trouble with the Medicare rule. That's about 65 to 70% of all cancer patients in the 65 and older population. Commercial insurers get equally sticky about that topic, and I don't know if they have created exceptions around that. And the other problem is that you don't necessarily always have good communication in that golden triangle between operator who gets the tumor, surgeon or biopsy, the pathologist in the hospital, and the medical oncologist. Because don't forget, the pathologist is working in a pathology department. That's a revenue center for the hospital. So they want to take a few slices of that tissue for immunohistochemistry, some PCR amplifications, whatever. And so depending on what you're doing, if you're doing a brush biopsy in cholangiocarcinoma, you may not have enough tissue left to do a free-form 1-paraffin embedded block to send off for NGS. So you have a lot of logistical but also operational problems that need to be surmounted. And my company and others, we kind of work to try to get everybody together on that. But it's a real problem.
Thank you. I have a question for Dr. Yellowhair, but I am a thoracic oncologist, and I can't, I do want to share one perspective because lung cancer is the poster child for molecular testing, and every patient needs molecular testing. And to Dr. Symington's question, what we realized after years of going back and forth with the surgeons and pulmonologists is that we decided to let the pathologist do the reflex testing because yes, there is a 14-day rule, but that rule only applies to liquid biopsies. So for tissue testing, if your patient had surgery and they're in the hospital and they had prolonged complications, you can still ask the pathologist to send it to Caris, Tempus, Foundation. I'm going to say all of them so that there's no conflict. But you can send it to any of those, and they can cut the slides and send it out. Of course, for every cancer, it's a different set of testing. So it's really the pathologist that will be the one that can save everyone's time. We've tried it with the surgeons and the pulmonologists. It's not going to work. But that really worked. And the 14-day rule was an issue for liquid testing. So any ctDNA testing, you will have to wait for them to get out of the hospital. But for tissue, absolutely. And then one other thing that I didn't want to say is that in your state legislative discussions around molecular testing does help. We passed a bill in the state of Rhode Island allowing everyone to have comprehensive molecular testing, and even if their insurance denies it, the health systems have to cover it. So that may be something.
There's a similar bill in Washington State.
Excellent. So I think that can add an extra layer of hesitancy from providers.
Thank you both.
Thank you. But my real question was for Dr. Yellowhair. So I practice in Rhode Island, and we have a sizable population of Native Americans that I don't know the name of the tribe, but I've taken care of a few of the patients from those. And one of the things that I encountered was that every discussion I had with them, they went back and they had discussions within their elders in the community. So it was limited understanding, but I did understood that there was a lot of discussion within the elders, and then those patients would come back to me and share their decisions that they made after discussing. So there was a lot of, that community discussion that happened, and I always wondered how I could help make these discussions better, and how, as providers across the country, we can improve maybe outreach and trust building within.
Yeah, great question. It's something that I was at a meeting last week with NIH with a lot of different cancers across the country, and so we were talking about two key things. One, when a patient gets first diagnosed, and then how much time is given for them to actually start their treatment care process. And if the conversations that we were having is, some people feel like they just get bombarded right away, like you need to do this, you need to do X, Y, Z within this certain time frame, but coming from a tribal perspective, having to have time to actually process the information, talk about it, and speak with it with your family. As I mentioned about how how Native Americans look at at care, we want to make sure that we're making the right choices for ourselves. So we want to consult our family. We want to consult our traditional practitioners and get their perspective. And so one option was maybe you expand the time and let the family have time to process and speak to the elders and get a clearer picture for them on how they want to proceed. But the other thing that we were also discussing is the possibility, and I know for Arizona, Medicare is actually paying for traditional practitioners as far as part of their care team. And so we're trying to figure out how can we have a traditional practitioner or a medicine man as part of the care team, so that way they feel like their decisions are being heard, their thoughts are being heard, so it's part of the process of the whole entire care plan working together. So bridging together Western medicine with also the cultural traditional medicines that we have and that we practice.
Okay, thank you.
Thank you all so much. So Brian Persing from Mississippi. I'll say that we'll put a plug in for session 6B today, because that's advocacy in action. So just to let you know, Mississippi did pass biomarker legislation this last week, signed by the governor. So we're excited about that. I think one of the things that's come up and dabbling in thoracic oncology, there was a great article done in the Journal of Precision Oncology through ASCO in 22 by Dr. Sadiq that actually talked about the testing and the gaps where we lose patients from beginning to end. And I think one of the things that's most disheartening, and I would love to hear y'all's thoughts on this, we have almost 30% of patients that end up with the biomarker available and then never receive therapy with that actionable mutation. And so hearing either some of y'all's experiences or thoughts or ideas would be great.
Yeah, I guess I can start. It's a huge, I 100% agree with you, it's a huge problem. I think there are some very nice studies that show that along the path of obtaining testing or getting targeted therapy, there's dropout at every single step of the way, which is hard, but also I feel like there are opportunities for interventions, thinking a little bit about implementation science and where we can sort of get the best bang for our buck in terms of getting people from beginning to end. The question about actually receiving targeted therapy after you have an NGS is also very real. Here in Washington State, there's a couple of projects, one of them that I'm leading that offers genetic, kind of again, trying to fill these gaps. Getting folks actually genetic testing through the University of Washington Fred Hutch Oncoplex system, where they then have access to a precision medicine expert and have the opportunity to join in a molecular tumor boards. This is now specific for prostate cancer. But I feel like a lot of the barriers for actually obtaining the testing is we hear from community providers all the time, we know what to do with like BRCA, you know, these obvious ones, but what to do about the ones that just are a little unclear. They're trying to match treatments for their patients. And so I feel like that extra step of having access to an expert that can actually interpret the findings for you and help provide information so that your patient actually gets targeted therapy is key.
I will echo just saying the use of navigators. And so one of the things that we're doing at our university is implementing a clinical trials navigator. So they help patients and educate family members as well about, one, what is a clinical trial, what to expect, and pretty much help working with them through the whole course of the clinical trial to reduce dropout and making sure that people stick to the protocol or adhere to the study. And so we're finding that it works wonders. And so again, just a big advocate for navigation, and they actually are able to spend more time with the patients rather than, because granted, oncologists can only spend 15 to 20 minutes, but I think with the navigators there in place and having access to the navigators, that goes a long way.
Yeah, to harp on that theme of oncologists have limited time per patient, when the report is clear, easy to read, and actionable, then actionable things happen. And if there's a report that has findings that doesn't quite sit right with the oncologist, you should be able to pick up the phone and call somebody. And so, you know, as was said earlier, you know, that range of companies that were listed, they all have people at the other end of the phone who will listen and can tell you about, you know, what's your VAF cutoff, what's this, what's that, what to do. And I'll just put a last plug in for AI, AI that's more accurate and better than ChatGPT. You know, closed systems that you've curated all the data in will give very, very accurate answers regarding this patient, this clinical situation, this genomic finding. These drug therapies are the proper decision analysis from a decision support thing. Yeah.
Thank you.
Before we go further, I want to introduce our fourth panelist, Dr. Jerry Radich. So Dr. Radich is a professor at Fred Hutch Cancer Center. He directs the molecular genetics lab, and you know, most of what we talked about is related to disparities in precision oncology in the US, but he has taken it to the next level. He's taking the genetics testing to other underserved parts of the world. And he had a good reason to be late. He was giving a grand rounds presentation at Fred Hutch, which finishes at 9, and miraculously in 30 minutes, he somehow navigated Seattle traffic in peak hour and made it here. And excitingly, he also has a New England Journal publication about to come out anytime. So please welcome Dr. Radich. Today. All right. So yes, please go ahead with it. Yeah, go ahead.
I'm very sorry. One of my colleagues offered me her Porsche to try to get here faster, but I thought I should try to maintain sanity.
Okay, thank you. My name is Mary Maeda. I'm founder of a local nonprofit called Canine Cancer Research Alliance. The founders are mostly former DARPA program managers who love dogs and who wants to cure cancer in dogs. And so we are supporting a number of very promising immunotherapy development and clinical trials with canine patients to bring the therapy to dogs, not to evaluate in dogs and skip to humans. So my question to you is, once we have a therapy that's quite affordable, so it could be used in veterinary setting, so treatments are not $100,000, but more like, you know, hundreds to low thousands of dollars, and they're very safe, and they're very, very efficacious because we're trying to use combination immunotherapy. Now, if you want to make that available to humans, and we do go through FDA trials and raise funds, it's going to end up being expensive again. So do you have any advice for us on if we have a very winning canine immunotherapy, how do we make it available to, you know, lower income countries? And which countries should we go to? What organization should we partner with to make that available as human medicine?
We have quite a few experts here from other countries, and I don't know what the drug regulatory processes are over there. Certainly, I think that will probably not fly in the US. I think it's fair to say. I don't know. I think there are some ethical concerns with that too, that if a drug hasn't been tested properly in humans, should we use it if we have nothing else better? I can see both sides of it, but there probably has to be some data in humans before we start using it. So that would be my...
Oh, absolutely, yeah. It has to be tested. So then where do we go? Where do we run clinical trials so that clinical trials don't end up costing hundreds of millions of dollars?
Yeah, I can tell you from my J&J experience that their cell therapy, their CAR T for myeloma, really came from the partnership with the IP from Legend Pharmaceuticals, who did their clinical trials in China. And I was amazed when I looked at the clinical trial data, because many of those patients would never have, they would have been kicked off the rolls in the US. There were 6 lines of therapy, really in terrible shape. And the fact that they received their cellular therapy after their T cells were harvested and the virus was put in it and they were reinfused, the fact that they did well, when I saw that, I said, I know this drug's going to be a winner. But Legend Pharmaceuticals could never have done those trials in the US because it would have been incredibly expensive, against regulatory protocols, and they would have kicked half the people who were in the trial off the trial. So look for countries who have that pattern. You might get something done.
Okay, thank you.
My question is for Dr. Yellowhair, and you showed a slide of oncologists relative to population, and it was really quite striking, and it looks like sub-Saharan Africa. But a reflection of my naivety, this is in Arizona, and you mentioned 3 big cities, and probably there are several hundred oncologists or more. Actually, I know there are well more than that in the state of Arizona. So could you explain to the group what is the process for access to oncologic care on the reservation? What's paid for? How do you, and I'm also curious, how do you recruit oncologists to serve on the reservation too?
Oh, if I had the answers to all of those, I'd be a very rich woman, wouldn't I? So no, that has been, again, another question, not only just in Arizona, but across the board, across Indian country in general, of how patients get referred care to get oncology services and clinical care for cancer, in particular, specialty care. And so, again, I've even asked this with a lot of our FQHCs as well as IHS facilities and how they go about referring people out. And so a lot of it is just based on availability and how soon someone can get seen as far as getting cancer care. There's no real standard operating procedure as far as how the referral process works. Especially for tribes, federally recognized tribes, they usually tend to go to IHS facilities or tribally run 638 healthcare facilities. And so those initial costs, they're, in a way, it's kind of how Medicare works for some of the tribes as far as getting general care, but as far as specialty care, I'm not too sure on that. And so that is one question about how can we get, I mean, for us as a cancer center at U of A, yes, we'd love to have people come to our center, but at the end of the day, we just want people to go get care where they need to get the care from. And so, especially with the Navajo Nation, I use this data from 2019 is because as of June of 2019, one of our FQHCs in Tuba City, which is in between Flagstaff and the Four Corners area, they've actually opened up their own specialty care clinic. And so they typically have, when they started, they had 2 oncologists there. There were a couple. They serviced that area. And so unfortunately for them, they retired. And so they moved out of state. And so that clinic, the specialty care program, had to shut down for almost 6 months because they didn't have someone to do the oncology care. And so after they finally did all the recertifications, they are actually working with contract care. So someone from, I think it was Colorado, does the clinic once a month. And so some of the goals in my office is to actually try to help to see how our cancer center can also do some type of telehealth or to help out, because just due to the limited availability of the contract care oncologists, all the appointments are usually booked. And so if there's not enough, if you can't get an appointment, you still have to go off-site to other areas to get care.
Manish Kohli, University of Utah, Huntsman. This is not a question, more it is a point of discussion, and I'd love to know your take on it, the panel's take on it. 90% of our drugs are not directed against altered DNA. They're directed against proteins. But we talk a lot about CGPs. We also talk about CGPs, panels between 360 genes, 500 genes, so on and so forth. There's nothing precise about these panels when we talk about doing one particular drug against one particular molecule that may be aberrant on those panels. So the question I have for you is, in cost effectiveness, trying to use panels which are useful for drug direction, especially in low-income and middle-income countries, is there some traction that could help in delivery of cancer care in a more meaningful way rather than increase costs? The second thing is, don't forget, just having a CGP alone and matching it to a drug in itself, trial after trial, prospective trial after prospective trial has shown, that is not a panacea for or a solution for success. There have been innumerable trials where GMTs, genotype matched treatments, have failed, just a little above placebo maybe. I think we are in that evolutionary phase, and I'd love to hear your thoughts over here, where we can try and finesse things in precision medicine in a slightly more cost-effective way, which could therefore be, circulated in greater populations with more bang for the buck, so to speak. Just some thoughts.
Well, I'll just chime in by stating something that we would talk about at lunch when I was in the insurance industry, which is that population health is what you recommend for other people. So we'll start there. It's true that not all gene therapies actually succeed, even if you hit the target. But I like to look at it as a journey. Low-income people in other countries now can take flights to visit relatives in America, visit relatives wherever they live. But when you put a high bar on something regarding what you want it to be, it's like saying, I look at the Wright brothers airplane, and we should never do air travel because I can't put my luggage in it and fly to France. We're in an evolution.
You see, the issue in low and, this is disparities, the conference as such, the issue in low and middle income countries is that the person with cancer sells off his or her lands to get onto that airplane for one reason. And there's a disparity that gets created. And all that I'm asking is there a way we can finesse our science in a more actionable way, for use of another word, rather than have a CGP panel of 500 genes for delivering care, which in itself costs quite a fortune for people outside in the world, not just people who can afford it. It's about accessibility of science here I'm talking about.
I mean, we and others have programs in second and third world countries where you have access to the testing. You can easily ship an FFPE tissue block anywhere in the world, and it's cheap. Then you get the result back. You could do it by email. The real cost is the drugs. You could do that locally. It's not the testing.
And can I maybe bring in Dr. Radich here? Can you tell us about your work about how to bring testing to the underserved areas and also about your drug program to match that testing?
Yeah, so, hi again, sorry, late. So most of the work we do in the lab is in the low and middle income settings are with a specific disease, chronic myeloid leukemia, where there's a perfect target, right, therapy. And so we work mostly with the Max Foundation, who you may well know is out of Seattle. And so they've worked for ages now with drug companies. And basically the deal is that Max can diagnose a patient in CML around the world. They will get free drug for life. And so that's a lot, because now with this therapy, we've shown that people on this program live a normal lifespan like you would see if you had CML in Seattle. And so basically, what these drug companies are committing to is the cost of that drug in the US is $100,000. So $100,000 per patient for life. And there's 5 companies that are involved in doing this and have signed on, and we've been doing this now for 20 years. The issue, of course, is how to do molecular testing. We've developed some assays that can do it locally, but things that could be used while we develop them for low-middle-income countries, but can be done here, some of the questions I'm hearing, is one is, how do you get cells, blood to specialized centers? It costs. I mean, in Africa, to send a vial of blood to Seattle is $500. That's not sustainable. So we figured out ways to basically put dried blood spot stuff, right? So this is a fake one, but you can basically put dried blood spots and do DNA or RNA. These can take 3 months to get to Seattle if you want to. And we can do RNA sequencing on it. We can do DNA panels on it. We can do whole genome sequencing panel on it. And so the average turnaround time once a sample hits our lab for whole genome or for next generation sequencing panel is 3 days. So it's pretty rapid. If you want to do single targets, it's faster than that. And there are now ways that you can basically, so a lot of places have access getting syringes and the like. This is what we call a medical leach. Probably not the best name for it. But you put it on your arm and you press, and it basically collects blood onto a dried blood spot, which then you can ship. And you can basically, we're probably getting to the age now where we can just send these to people and have them do their own diagnostic or monitoring done for relatively cheap. So that's all can be done tomorrow, basically. But I agree that the main cost of all of this is the drug. We can figure out ways to subsidize. We've been doing testing for patients, thousands of patients, for years free. We can figure out how to do that, right? But it's marginal compared to the cost of the drug. So that's.
Hong Ho Wang from Tuskegee University. So I'm not an oncologist or pathologist. So I'm a cancer researcher. As you know, that Tuskegee is a historical, one of the HBCUs. So, we have, our research mainly, we want to identify, biomarkers or therapeutic targets. But, we know we have really low sample set from African American populations. So what are the strategies? We heard a lot of comments and about the barrier, and what are the strategies, most important, effective strategies we can use in our state, in terms of the whole U.S.? Thanks.
Well, I can start just speaking. Historical trauma is a big thing, especially in communities that have been historically affected by this. And so, again, Tuskegee, you have the Airman Study. And so I would recommend maybe working with your community outreach engagement department at your university. Usually the cancer centers have them there. And as we always talk about, having people from the community help design your study in mind, that goes a long way. If you talk with your community advisory board, get them involved in the study process. They will tell you what's important to them, and if you find a study that has huge significance value and it's something that hasn't really been looked at, but it's a community need, I think it has to come from the community in order to help with what you're looking at.
Yeah, I completely agree with that. I mean, I think there is real historical trauma that we all as researchers have to be aware about, but there is also pretty strong data that if you offer, if an oncologist offers a clinical trial to a patient, 60 to 70% of patients will actually say yes to that clinical trial. So I think it's incumbent upon us as oncologists, when we see these patients, to talk about clinical trials in a way that is standardized. I say, regardless of the race of my patient, where they're, I don't assume they live in Spokane, so they're not going to come for a clinical trial, right? Every patient, I have the same, spiel, we have these trials available, we'd like to talk to you about them. Genetic testing is standard for everybody. Here's why it's important. And then I 100% agree with Dr. Yellowhair about using community resources to sort of help design your studies. And, patients in every community go back and talk to their loved ones, their families, their friends. We have a couple programs here where for prostate cancer specifically, we're looking at kind of polygenic risk scores, and we're going to the communities that serve a lot of underrepresented patients, and we're partnering with them and bringing folks into the community. And I think don't underestimate the power of your community or the power of an individual provider speaking to a patient about a trial or genetic testing.
And I will add one more important thing is disseminating that information back to the community. That is key because, again, we don't want to feel like we're constantly being targeted for research, but yet we don't know what the outcomes of this research are. So again, it has to be bidirectional. So working with your COE, working with your CAB, getting that information back out, because I don't know how many times I've heard from my own community members, hey, I participated in this study, tell me what happened. And I'm like, ooh, I'm sorry, I don't know what study you're referring to. So that is key. Send your researchers out there and engage with community members. That goes a long way.
Yeah, on the outreach side, once you have a culturally competent message, then you need to get to the people. And we hear a lot, especially lately, about how terrible social media is and, this is the devil. But once you've got the agreement, you can actually use, smartphone. You can use your phone as a way to push that message out because everybody has one. Even low socioeconomic, groups have it. And the reason is because if they don't have a laptop, this is how they really access the electronic environment.
But other tribes, they may not have a tribal IRB, so they might refer you over to the area Indian Health Services IRB format. Just to give an example, and this is something that everyone should know, especially if you want to work with tribal communities, the word is patience. And so we're currently trying to launch a community health assessment survey focus on cancer with one of our tribes. And we started this initiative in 2021. So we're still finally getting the last portion of tribal IRB approval to get it going. And so with this particular survey, what we're also taking into account is tribal sovereignty and the right for the tribe to have own their own data. I am currently a co-PI on this, and I won't have access to the data. So we are technically just being technical support for the tribe. We're training their people how to conduct the survey, collect the data, working with their epidemiologist team so we can help them with the whole survey needs, the collection, the analysis, and what they also want our help with is with disseminating the information back to the community. And so, again, a lot of patience, and so that's the best that I can offer and let people know, especially when we work with NIH and NCI, we have to tell them, like, it's not a quick hurdle, and so it's just learning how to be patient and working with the tribes. And that also goes a long way with building that relationship with the tribes. And so once they see that you're in for the long run, some of the studies afterwards tend to go by a lot quicker.
Yeah, we have 1 minute left. So.
Thank you, David. Thank you for giving me that chance to speak. And I will be brief about it. This is not really a question. It's more of a reflective perspective. And I was sitting down and I was just listening about people talk about the first world, the second world, and the third world countries. And one of the things I want to make everybody remember, in every country there's a first world, a second world, and a third world. There is first world in the US. I have worked in a lot of those places. And in Nigeria, there is, for example, first world countries. I will give you an example. My mother and my mother-in-laws, my mother is 94, and my mother-in-law both have breast cancer, and they are both 20 years post-treatment. But the reason they are still here is because in Nigeria, somebody made the diagnosis correct. And the treatment, we can just bring them to the US. Myself and my wife are both doctors here in the US who can afford it. Why am I saying that? They are first world people in a third world country. So diagnosis is important. So when you miss those things and talk about, it's not about the diagnosis, it's about the treatment. I couldn't sit down because I remember what I put down on my table. I learned it from my microbiology teacher as a medical student in Nigeria, who is a British scholar. He says, make the right diagnosis and every fool can treat. And the reason is that if you don't make the right diagnosis, people keep treating the wrong things. So in those places, if that person had made the wrong diagnosis in Nigeria, my mother and my mother-in-law would be dead today. So diagnosis is important because no matter what part of the world they live, first, second, or third world, if you make that diagnosis correctly, any fool can treat. Thank you.
Thank you. We're going to break for 15 minutes. I'd like to especially thank Dr. Lee and Dr. Bhatia for organizing this great panel discussion. Dr. Radich, Dr. Klein, Dr. Khan, Dr. Yellowhair, thank you all very much for your participation.